doing and likely will continue to do is the 7 to 8 a.m. session. We have 8 topics that we continue to cycle through. So basically, it's the same 8 topics over 8 weeks. We do update the information as we see new literature come out on these topics. So I went through this one about 3 months ago and tried to include new research related to diversion. So we do that periodically, but it's the same basic topic that rotates. And then our 3 to 4 p.m., what we call our continuing education sessions, those are different topics, and those typically don't recycle until 8 or 9 months. And then again, we try and look at the current research and incorporate that into the presentation. So that's just a little background. These are our Mentor Echo Global Learning Objectives, the big umbrella that we try and meet as best we can with each of these presentations. These are the objectives for this specific session. First of all, look at some of the prevalence of diversion and MAT, including specifically in Ohio, understand some of the risks associated with diversion, MAT, and appreciate some strategies to reduce the risk of diversion. This is one topic where, since I'm a psychologist and I have to worry about things like child abuse, homicide, and suicide, I don't have to worry about people diverting medications I prescribe. So I walk very softly on this. I just present in as neutral of a way as I can what the research suggests, and you all can draw your own conclusions and have your own points about it. One thing I would say, though, is if you read the scholarly literature, it's really clear. It kind of gets to what Dr. Marsh was saying, is that from a public health perspective, there's not a lot of concern about diverted medications. The rationale being that someone who's taking a diverted buprenorphine on the street is less likely to have a negative consequence than someone who's using heroin on the street. That's a public health perspective, and that's kind of looking at things in an aggregate way, right? But on the individual provider level, obviously you want to ensure that your medications are being used appropriately to the best of your ability. The research also suggests very much like this, that they are, like a lot of the authors argue, that the policies that restrict access to buprenorphine, and a comparison country is France, oftentimes that's mentioned, where there's significantly less policies that restrict access to buprenorphine, really kind of miss the mark and make it harder for people to access buprenorphine regularly, and therefore drive an illicit market of this medication. So, it's kind of this weighing the pros and cons on a macro level, but obviously on an individual level too, that there's that the research kind of struggles with. So this is still the case. This is an article from 2014 that very clearly stated it. But at this point, there's a lack of controlled studies that examine interventions to screen, monitor, and reduce medication diversion, all that together. So we just don't have enough data to suggest, okay, if you use this way of screening and then this accompanying intervention, that it's going to be less likely to lead to diversion than if you use this type of screening and this type of intervention coupled together. So we have to learn, use kind of what we've learned in our own practice. I always mention this. I get annoyed because when I read the scholarly literature, it talks about misuse and diversion like they're the same thing, and they're very different. Some studies do tease them apart, but many lump them together, which is problematic. Misuse is the person is using the prescribed drug that was prescribed to them, but they're doing it in a way that varies from the accepted medical practice. So they're taking a higher dose, they're taking it more regularly, they're injecting, and yes, it's hard for people to understand why based on the pharmacology, but people are still, there's a group of people who still inject Suboxone. Again, we're not exactly certain why, but there are a group of people who continue to do that, as well as intranasal smoking. We had a thing about last week about Juuls, so who knows what's happening with Juuls and buprenorphine. I shouldn't say Juul because that's the company name, but you know what I mean, the e-cigarettes. So this was a 2014 study in the US, and the past month injection among persons presenting for MAT was 45% for buprenorphine and 16% for Suboxone. So there was is less than people injecting the mono product, but the combo product, 16% of folks had been injecting that combo product. But that's misuse, and we're focusing on diversion, which is voluntary or involuntary, so stolen, unauthorized rerouting or appropriation of substance. So buprenorphine in this case. I start with this slide because I think culturally in the United States, we don't think about diversion in general as a big issue. This is a 2012 study from SAMHSA, and essentially they call up people and ask about people using medications that were prescribed to them. And out of 17 million people in the sample, 18% of the sample reported that they used stimulants, benzodiazepines, opioids that were not prescribed to them. And then another study in 2008 with other types of medications found that 23% of respondents shared the prescriptions and 27% borrowed prescriptions, things like allergy medications, pain relievers, antibiotics. So culturally, sometimes we don't think about, oh, you seem like you have whatever, I'll give you this medication, my allergy medication. Seems like you have, you're having allergies. So I think sometimes people just don't understand that that's problematic. So specific to MAT, so surveys of U.S. patients enrolled in MAT, so this was methadone or buprenorphine, 18% of the sample reported that they had sold, given away, or shared their prescription. And I think this is a pretty good ballpark estimate, at least based on the studies that I've looked at, which is pretty much the majority of them. About 20% at some point have sold, given away, or shared the prescription. Studies find that all three sublingual formulations are abused or diverted, but the sublingual film is the less likely to be abused and diverted than the tablet formulation. And you also see in Ohio, typically you can get more on the street from the tablet Suboxone than you can the film Suboxone. So here, and that's a perfect segue. So diversion of Suboxone in Ohio. This was from our famous osamagram study, and this report came out in January 2018. So Suboxone, and this was, they kind of look at trends. There's probably a new one out, which I need to get for the next presentation, but I haven't checked yet. They do the study every 6 months. And essentially what they do is they look at, they sample people who are using, who have substance use disorders, who are in treatment, who are not in treatment, as well as treatment providers and law enforcement. So they try and get a picture based on all of those folks that what's the landscape of drug use across regions in Ohio. So at this point in time, they were indicating that Suboxone was highly available for illicit use throughout Ohio, and that for whatever reason at that point in time, there'd been a big spike in Toledo in that region. When they asked participants, why is there all this highly available Suboxone, the folks indicated that it was the less regulated Suboxone clinics that they termed cash and carry, and then the dreaded dark web, so people getting things on the dark web, whatever that is. And then Suboxone was indicated by participants as a form of currency. So, you could trade your couple of doses of Suboxone for some other drugs, and it's referred to on the street sometimes as octagons, rounds, subs. It's hard to keep up with drug lingo. There's probably 5 new terms for all these things now. Why were people also saying that they were getting diverted Suboxone in Ohio? So people were reporting that they were using Suboxone to avoid withdrawal. And one thing you'll see a pattern when there's a large number of overdoses, like for example in Cuyahoga County, what happened, what was it, about 3 weeks or a month ago, something like that. I would bet there was a lot of people during that period of time who were trying very hard to buy Suboxone on the street as opposed to heroin on the street, if they in fact wanted to live. So that will happen when there's a region where all of a sudden there's a number of overdose deaths. People will try and get Suboxone during that time to kind of wait out that quote unquote bad batch, which is very interesting. Like I said, I've been doing this since 1995. Before fentanyl and carfentanil were on the streets, people ran towards those drugs because they thought they were going to get a better high. And now it's so dangerous, you see more of a pattern of people avoiding and trying to get diverted Suboxone. So like I mentioned, an 8 milligram film strip of Suboxone in Ohio would get you somewhere between $10 and $30. An 8 milligram tablet would get you around 20 to 25. So in general, a tablet you're going to earn more money from in Ohio. So participants reported the most common route of administration was oral. So most people who are getting diverted Suboxone were taking it orally. Again, you got this group of people. These are folks who are not in treatment, who are using intravenously, 10 to 30%. And that number tends to kind of hold. You got this, 10 to 30% of folks who are using IV. So this was, well, to me, this was interesting. Ohio is in a lot of these studies for obvious reasons. But they were interviewing 18 different alcohol and drug mental service board representatives. For whatever reason, this study, they didn't tell you the number of individual participants, but they interviewed people from 18 mental health, alcohol, and drug boards. And they're wondering, a number of things, but specific to this presentation, about the barriers to buprenorphine treatment. And they conducted these surveys in 2015. And this is a pattern you see a lot, both just talking to people as well as looking at the research, that a barrier was listed as the public as well as local law enforcement was having an issue with it being sold on the street, diversion, those kind of things. So basically the public begins to get in an uproar that there's too much buprenorphine, there's too many people on the street who are getting it. And then therefore there's less likely the people to prescribe it. And I'll say Child Protective Services is also in that camp. And even where I'm at in Rootstown, Child Protective Services has a major issue with folks who are involved in the Division of Children and Family Service system taking Suboxone because they're so concerned that they're going to divert their medications. So you got people who are having a hard time reunifying with their kids because they can't get the right treatment. So anyways, that's was a study of the boards and their belief about what were the barriers to buprenorphine. So this was a 2017 study where they looked at the rationale for diversion in MAT. So this was 200 folks from 2015 to 2016. So basically asking what would make it okay for you to divert your medication. So 22% of the samples said it was okay to share buprenorphine with a dope sick friend. So they had somebody who was dope sick, then they would share it. It was okay, 37% to save lives. So again, that's that kind of bad batch theory. Okay, there's just bad batch out there. I got buddies who use heroin. I'll give them some of my medication so they don't die. And then about 52% of the samples said it was never okay to share or divert medication. So of the 107 patients in that sample who did divert, other rationale was 59% of that 107 said to help a friend. So again, that can be someone who's dope sick or someone who they're concerned is going to die. 57% said that they needed money. So obviously sometimes people may do it to help a friend. Sometimes they may do it to need money, the same person. 27% said they didn't need the whole dose. So that kind of gets it. Someone said earlier that when they were concerned about their patient diverting, they gave them a smaller doses. So that kind of goes to that rationale. And they didn't want the whole dose. They wanted to get high. You talk about drug holidays. Sometimes people take a buprenorphine holiday, quote unquote, and then they use heroin or their other opioid of choice during that period. Consequences of diversion, obviously, like Dr. Marsh referred to, it can lead to harmful medical consequences, including fatal overdose, especially if people are taking other central nervous system depressants. It can lead to harmful social consequences. Certainly, obviously, it's illegal, so you can wind up catching a criminal case. You may lose custody of your kids. There's lots of other outcomes that can be very negative. And like you all mentioned, it can jeopardize treatment participation on an individual level, but also the availability of MAT on more of a macro level. Again, if we get very concerned about diverted MAT and are not supportive of practices, then we may have less people actually able to get it. Overall, the safety profile of buprenorphine appears superior to methadone, with 2 to 3-fold lower rates of drug diversion reports. That's always surprising to me with how methadone people are getting the typically daily doses, but also less reports to poison call centers than methadone. More than 50% of buprenorphine-related emergency department visits are for non-medical use of the drug, so someone who is not under the care of a physician or nurse practitioner or physician assistant. The Center for Disease Control reported that Suboxone caused 9.5% of hospitalizations for drug ingestion by children less than 6 years, lower rates for film than tablets. So clearly ensuring that your patients have a strategy to keep it away from children is very important. So this was a study of 1,100 buprenorphine prescribers all across the United States. And they were kind of looking at the relationships between the prescriber and patient characteristics and prescriber perceptions and approaches regarding diversion. So it was a big correlational study where they were looking at correlations among a number of factors. So 80%, first of all, roughly 80%, assessed via urine drug screen for the presence of bup. They didn't specify norbup, but we would suspect that they were screening for the presence of norbup as well, for obvious reasons. 35% saw patients 2 times a month during their first 60 days. 26% of the samples saw their patients 1 time a week during their first 60 days. Again, that kind of rationale of seeing someone more regularly at the beginning to make sure that they're complying with what your treatment agreement is before things get to be too drawn out. And 66% initiated medication counts, like what we heard about with Dr. Liang. So this is further with that study. 50% had a strong agreement with terminating patients who diverted. 29%, almost 30% agreement, so not strong agreement, but agreement with terminating patients diverting. So you got about 80% of the sample pretty much in favor of terminating patients who diverted. About 50% reported that diversion was a moderate community problem. So, somewhat substantial community problem. 23% reported it was a significant, so a more serious problem, and 11% reported it as an extremely significant problem. Because what they wanted to look at ultimately was the relationship between the community's perception of diversion and the prescriber's basically practices. And they did find that the willingness to terminate patients was significantly associated with perception that diversion was a community problem. So the more the community perceived it as a problem, the more likely that the prescriber was to terminate the patient, which is kind of interesting to think about. And psychiatrists and addiction specialists were less willing to terminate treatment based on suspected diversion than were non-addiction or non-psychiatry prescribers. They didn't theorize about why that was, but we could all theorize for ourselves why that would be. And this is just one study, so who knows? So what can you do? First thing I'm going to show really quickly, because the research is, although it's for methadone maintenance treatment programs, they lump it in with kind of practices around buprenorphine, or at least a template to go by, to basically begin to be concerned about diversion and allowing people to have sort of more autonomy in their buprenorphine treatment, coming less regularly, that type of thing. So no recent abuse of drugs, including alcohol, attending the clinic regularly. Unlike Dr. Dallas Reyes' new patient, no serious behavioral problems at the clinic, no known recent illegal activity, stable home and social relationships, their length of time in comprehensive treatment, kind of like what Dr. Goldman was referring to as, a patient who's been in treatment for a while and then all of a sudden there seems to be some diversion. Do you think about that differently because the person's been in treatment for a while and had been seemingly successful? Assurance to take home medications can be safely stored. And does the rehab outweigh the risk of diversion? And that's always a line, right? Which is hard. Is the person's quality of life seemingly better, though perhaps they're diverting here and there? And what does that mean in terms of whether or not I'm going to continue to keep them in treatment? So more specifically to outpatient based opioid treatment, what can you do? So obviously what we talked about, the urine tests for bup and norbup and other drugs of abuse, pill counts and medication log, which we heard about. The literature suggests it's really important to have in your treatment contract a statement that you have the right to call the patient in with 24-hour notice for unannounced random drug tests as well as a pill count, so that you can kind of have them report in with that 24-hour notice and ensuring that they understand that as a part of your treatment. Observed ingestion. And they argue that for people that you're concerned about, 3 times a week may be sufficient. Again, who's got the capacity to see people 3 times a week and observe them take their medication? Probably not all of you, maybe not any of you, but nonetheless, limited medication supply. So weekly or as little as over a course of 3 days. Clearly checking your Ohio automated prescription reporting system. You can begin to think about the buprenorphine extended release injection or the buprenorphine implant. Those could be other ways that hopefully folks haven't figured out how to divert those yet. What else can you do? Discuss diversion and misuse regularly with each patient. And they even argue as part of when you're meeting patients, get a sense of why would they think about diverting? What would be their rationale? When would they think it would be okay? And then having a conversation with them about how that is likely incongruent with your practice, and how can they cope with that? So I think Chris was saying we do have many people who have substance use problems are people pleasers, which just seems incongruent, but they have a hard time saying no to people. So sometimes helping people just be able to feel empowered to say no to someone who's trying to get their medication can be a strategy. Reviewing regularly the dose adequacy and the treatment response, using things like CALS to look at the patient who's saying that they're in withdrawal, but you can have a more objective way of measuring whether that seems like they really are in withdrawal, or they're just trying to sort of game you to get more buprenorphine. And examining, and this gets more at misuse, but examining any non-healing or fresh track marks or intranasal irritation. Contingency management, if you can. So when people are being very compliant with your treatment agreement, if they find it beneficial to come into appointments less regularly, then that's something you could do. They come to appointments less regularly. If that's something that's rewarding to them, that's not for everybody. Clearly going through your treatment agreements regularly and having a conversation about them. Collaborating with other treatment partners, pharmacists, which we already heard about. You can sometimes get a wealth of information from pharmacists, counselors, non-using family members. The literature does really highlight that if there's a non-using family member who lives in the house and your patient's willing to sign releases so you can communicate with that person can be a real asset for you with watching people take medications or letting you know if there's any issues. Access to full psychosocial treatment and appreciating the person's honesty about diversion and their rationale before the intervention. And that is my spiel. And let me see if I can stop share.